Olá, boa tarde. Eu sou a Isabela Salles, diretora do ABC Medical Academic Meeting. Bem-vindos às apresentações de trabalhos científicos. Antes de começar, gostaria de explicar como vai funcionar a presença. Vai ser um Google Forms que deve ser preenchido. O link está na descrição deste vídeo. Para completar o form, será necessário preencher com duas palavras-chave. Essas duas palavras estarão presentes ao longo das duas apresentações nesse vídeo. Obrigada!
Hello everyone, my name is Maria Laura. Fourth year student here at Faculdade Medicina do ABC. I'm going to present my case report. Everyone can see it?
Yes.
Okay. So let's begin. Well, I'm here to present a case report of a patient with Hemolytic-Uremic Syndrome that's being treated with Eculizumab. The introduction. What is Hemolytic-Uremic Syndrome? It is a thrombotic microangiopathy characterized by a classic triad. So we have anemia, thrombocytopenia, acute kidney injury. This syndrome is mostly divided into typical hues and atypical one. The typical one is common by infection of the bacterial Escherichia coli causing vomit, diarrhea. However, the atypical one has a process a little bit different. The atypical use is caused by a deregulation of the alternative path of the complement system. So it's a condition due to primary abnormalities in this complement pathway that leads to an excessive production of C3 and C5 proteins. This causes damage in the renal cells. This renal endothelial injury leads to a platelet recruitment and thrombosis formations in the renal microvasculature. This whole process can be initiated by one or more mutations and triggers, for example, upper infections, postpartum period, and gastroenteritis. This is our case report. We have a baby, 9 years old in 2014. He's male, and he went to the emergency care unit complaining about fever for 4 days. He was premature. He was born 28 weeks of gestational age. So he remained in the neonatal intensive care unit for 1 month. However, his parents denies any previous surgeries, medications, hospitalizations, loss of conscience, seizures. Everything seems normal, including his current development abilities. So he was diagnosed with tonsillitis and released with amoxicillin. However, after 2 days of antibiotic, the respiratory condition got worse. He went back to the emergency care unit where a new diagnosis of bronchiolitis was established with the prescription for nebulization with beta-2 agonist. After the first nebulization, the patient developed cyanosis and apnea. Therefore, it was necessary a neurotracheal intubation and continuous positive airway pressure, leading to his admission at the pediatric ICU at our Centro Hospitalar Municipal de Santo André. When he got there, His physical exam showed he was bleached, he had skin pallor, he was cyanotic, and his saturation of oxygen was low. He had bilateral subcrypting rails, decreased vesicular murmur, and a palpable liver 3 centimeters from the right costal margin. After some complementary exams, the laboratory test showed he had anemia since his hemoglobin was 9.1, low of 11 in children is considering anemia. And besides that, the chest x-ray of the pneumothorax at right showed a pneumothorax that was drained and had a passage of central venous catheter. Then he also evolved with hypertensive pneumothorax at left, which led to another drainage. The patient remained hemodynamically unstable with weak pulses, poor peripheral perfusion, and skin planar. His clinical improvement was with vasoactive drug infusion. He also presented oliguria and anuria with the administration of albumin and furosemide. However, he maintained a decrease in the diuresis and changes in renal functions that led to a peritoneal dialysis, and also the administration of vasoactive and 2 volumes of expansions due to the blood pressure that was very low. During his evolution, it was possible to observe violent lesions with swelling in upper limbs from the middle of the back to the finger tips. So heparin was introduced due to the suspect of thrombosis in the extremity vascularis. From the pictures described, the diagnosis hypotheses were acute breathing insufficiency, H1N1, Hemolytic-Uremic Syndrome. There were some exclusion diagnosed, like thrombotic thrombocytopenic purpura and von Willebrand factor disease. The TTP is also a microangiopathy is initiated by the metalloprotease ADAM-TS13 test. So the test came normal, so there was exclusion. And the von Willebrand was refuted by the hepatoglobin dosage. The patient evolved with oral tracheal intubation and peritoneal dialysis with reproduction, and it was stable. The atypical hemolytic-uremic syndrome hypothesis was investigated due to the absence of symptoms compatible with typical syndrome. So after the exclusions of those diagnoses, there was the confirmation of the diagnosis of atypical hemolytic-uremic syndrome and the introduction of the treatment with Eculizumab. His clinical response was regression of vascular necrosis in hands and fingers with loss of cutaneous tissues from the fingertips, and also a normalization of renal and vascular function that supported the suspect diagnosis. His current condition is that the patient receives the Eculizumab 49 without any adverse events. Our treatment. The treatment for atypical hemolytic-uremic syndrome was plasmapheresis and plasma administration. However, besides reducing the mortality by 25%, the renal involvement was not very good. So this treatment of choice was Eculizumab. The Eculizumab is a monoclonal anti-C5 antibody as an inhibitor of the final complement pathway. So working as an inhibitor of the final complement pathway, it prevents the excessive production of the protein C3 and C5, leading to an absence of kidney injury and a no platelet recruitment and no microangiopathic thrombosis. Here we have a picture. All photos were authorized by the responsible of the patient before treatment and after treatment. So, a typical hemolytic-uremic syndrome diagnosis was clinical and exclusionary because there are no definite tests that confirm this diagnosis. We observed that the patient had anemia, he had a kidney injury, he decreased diuresis, vasculitis of upper limbs. So this is consistent with the hemolytic-uremic syndrome triad. However, the typical one and other subtypes were excluded because they did not show typical symptoms like vomits, diarrhea, signs of infections. And triggering factor for the atypical one could be his pulmonary condition during the first year of his life. And this diagnosis hypothesis was strengthened by the favorable evolution of the patient after the introduction of Eculizumab. Eculizumab is one of the most expensive medications in the world. It costs almost like 1.16 million reais per year. It's immunosuppression, so it's very important for the patient to keep vaccination record update. It is not provided entirely by the Ministry of Health, but is in progress to be. Here we have a difference of during his hospitalizations and nowadays. He's a really sweet boy. This is the report's importance. This is to show the clinical evolution of pediatric patient with Hemolytic-Uremic Syndrome who presented an excellent clinical and laboratory response using Eculizumab, one of the most expensive drugs that is available free through SUS. Besides being not free for everyone, you can have it through. So it's to show the importance of SUS in our country, that people can have access to medications that are so expensive. This is my reference. Thank you, everyone. I appreciate your attention. I will stop sharing.
Thank you very much, Maria Laura. Now, Alessandra, please.
Thank you. So first of all, congratulations for the nice presentation. Really good English. One more. You guys from the ABC University. Congratulations to all. So my point is, I have some questions, but I try to resume some of them. Of course, you highlight the importance of treating the syndrome because it could be fatal for kids, of course. So the use of the medication is, I always forgot the name, is
Eculizumab.
Yes, Eculizumab. Yeah.
I took a time to learn how to speak too when I first saw it.
In my notes. So yeah, I saw here some recent publication, and I can send you after a lot of reference about the benefit of Eculizumab in a typical Hemolytic-Uremic Syndrome. I think this is your case, right? So my question is, there is no novelty in your case report. It's only important, of course. It's very important to do this diagnosis. But in your opinion, you think there is what is the novelty of your case besides the importance of treating this case, of course?
I don't say it's as a novelty because I don't think, like you said, it's something new, but it's when haste the importance because atypical use is not diagnosed by a test. So we have to show the importance of exclusive diagnosis. And I think one of the most relevant thing is that our SUS, because it's one of medication so expensive, and the value of SUS that we can have this medication there, because I think a few people in the world could pay 1.6 million reais per year on a medication. And I think is that the most important thing of my report case, and to enhance the importance of a typical Hemolytic-Uremic Syndrome that is not very common. It doesn't have a diagnosed test. It's made by exclusion.
Okay, yeah, but as an epidemiologist, I have to tell you, so that's why I'm asking. When you think to publish one case report, you have to thinking about the novelty of this case report, because if you have a lot of cases, it's not a case report, it's a series of cases. So I know it's rare, it's not a common condition for in this age. So maybe you can put these points to highlight the importance of case report, your case report. It's not only because it's a typical Uremic syndrome, you know, treating with Eculizumab, because we know this is an option. It's well known this is an option for the treatment. You know what I mean? So what's the relevance of your case report? The relevance of your case report is to talking about we're here in a public system in Brazil. It's a really good public system, and you have this medication here. It's very expensive all over the world. So it's possible to be aware about this case and treat with this medication because we have it here. And I don't know about the age of the kid. Maybe it's more, how can I say, uncommon in this age. So in resume, my suggestion, I think that you should highlight these points in your case.
Yes.
Publish this case report.
Thank you, Alessandra, very much. I haven't thought of that, but you highlight some points that it was really important. So it's really nice to have this feedback and things that I didn't thought, and you bring me up. It can really sum up and turn it into a better case report. So thank you very much. I appreciate your consideration.
Thank you.
Thank you, Alessandra. Now, Andrea, please.
Hi, Maria. Congratulations again. It was a very nice presentation, very clear. I have a few questions, and in a sense, I remember I was reading recently about AGUS and how it's being triggered. It can be triggered by the use of antibiotics, right? So this kid had taken antibiotics, no? And I'm not sure about if that is also related with the typical or atypical, the use of antibiotics to be triggering that. So that's my question in a sense of like just getting to know me, update on that thing. And I agree, and I agree with and I think like what is really nice about your case reports that you are all doing, some of you are doing, is kind of you never forget, because I think probably you all had like the cases, right? You're seeing the patients.
Yes, we've seen it.
And it's a very exciting experience in a sense of like you're gonna see, and you see how he got better and how important it is the case. And I think what Alessandra was mentioning, in a sense, if we want to publish, it's important for you to think about it. What do you want to highlight about this? No, is it also about, even if they didn't have the diarrhea, but he used antibiotics and then started using the symptoms, you're already thinking about AGUS.
Yes.
And I think, and again, about like the importance about being able to have this medication, Eculizumab, that is so expensive in the world, and then you have the system. So because, for instance, in your abstract, you kind of mentioned this, but then it got lost so what was the point about it? I understand it, but I think if you want to link this, you have to kind of make sure that how you're going to link this in a sense of people to have access to this kind of medications, being able to do the treatment. So what is the point that you want to more highlight as a
yes,
the study that you
want
to
make it this point more highlight to stand out of, this is what I want to make it important, and how we do it on the abstract. Yes.
Yeah, so but it's a very nice. So, but do you know if the antibiotics also triggers AGUS, that typical one?
I don't know. I haven't read it about it. And when we studied, Julia is taking notes because she's one of my partners in this one, and I was with her at the sickle cell. And we haven't heard it about antibiotics, but it's something we're definitely gonna search for it and see it. We saw that it had been triggered, that the relation that is been triggered by the upper air infections, but the antibiotics I didn't know, so I'm definitely gonna.
Yeah, I know it's that for that typical one, but I don't know if it's for that typical.
Typical.
Yeah.
Yes.
Mm-hmm. That's cool. Thank you.
Thank you very much.
Thank you, Andrea. Estelle now, please.
Julia and Maria Laura, this is a map. Okay. You are working together. Okay.
It's our fourth work together.
Opa!
We like working together.
We like working together.
Nice. You did very good job. Very, very good job. And your English is perfect. but I miss more information in your abstract.
Yes.
Your abstract and your presentation are very different because now I understand what happens. You know, the abstract was too short, and I really don't understand what is the mean of this case is rare. You know, as the others.
Yes.
Colleagues. Now,
Yes.
now I could understand. You know,
Yes.
if you're going to publish this, I suggest you that you find the incidence of this kind of thing in our country, because this is very
Yes.
nice. Then you know that, because if you show that this AGVUS is very rare, your case report will be more important, number one. And number two, if you're going to publish this out of our country, nobody knows what SUS is.
Yes.
And you must explain what it is, because overbroad, there's no SUS. Nobody
Yes.
what this is, and the importance of what you are really talking about. You know, this is very important abroad to know that we have a system that gives medications that are very expensive and so on. Now, you have 2 points to find out. One, the incidence of this, so your case will be very rare in our country, and then you show that our country have this kind of medication, even if it's expensive. I think it's very important to show overbroad our difficulties and our good things.
Yes.
And this will be very nice if you publish in this way.
Okay.
Congrats.
Thank you very much, Etel.
Congrats. Very nice.
Thank you.
Thank you, Etel. Now, Fernando, please. Fernando, we can't hear you. Fernando, we still can't hear you.
Why is this medication so expensive? That's a good question, and I don't know how to answer, but I will definitely look for it and study. I don't know why it's so expensive.
Can I just make a comment also, just following up what Etel mentioned? I think it's a nice point, as you were saying, and thinking about that now WHO is pushing universal health care for all the countries, and if you frame on that with that concept that the importance of universal health care, as Brazil is really one great examples of that, and there is such a need everywhere in US and so many other places. So you can push that if you frame in that sense and getting the data about drugs and how much is being offered in Brazil and blah blah blah. It's a good way for you to frame this, I think. And you can take a look on the WHO PAHO journals. I would think about it, that they would be like to see that.
Thank you, Andrea.
Agora, porque o Sanaflix veio para mudar o jeito como você estuda medicina e mudar para melhor. Primeiro, você pode confiar na gente. Nós somos o maior projeto de educação médica do Brasil. E não é só porque temos estudantes em todos os estados brasileiros e em 10 países no mundo. Nem porque tem estudantes de medicina em mais de 300 faculdades do Brasil usando o Sanaflix. É porque temos uma equipe de mais de 150 pessoas trabalhando para melhorar a qualidade do seu estudo e a maneira como ele chega até você. Nós nascemos da vontade de revolucionar a maneira como você tem acesso à educação médica. A gente acredita que o valor que você dá para a oportunidade de estudar com a gente é o investimento no profissional médico que você vai conseguir ser. Por isso, é importante que você possa acessar a gente de onde estiver. Por exemplo, se você precisa usar o seu Netflix além do desktop, desenvolvemos o nosso aplicativo. Assim você pode otimizar seu tempo aproveitando o nosso material de qualquer lugar e com o mesmo conteúdo. Afinal, quem estuda com a gente sabe bem o que a gente tem de bom. São mais de 700 resumos para você fixar o que aprendeu, 300 fluxogramas para te ajudar a conectar os assuntos, 700 mapas mentais para estudar de forma ativa e, claro, mais de 1.600 videoaulas para assistir quantas vezes quiser. 4,5 de 5 é a nota geral das aulas por nossos estudantes. Elas são dinâmicas e objetivas e estão sempre melhores. Temos uma preocupação especial em aperfeiçoar a metodologia e a didática da nossa equipe de professores padrão USP.
Eu acredito no seu Netflix e eu invisto meu tempo na preparação das aulas porque eu lembro de mim. Quando eu estava no 4º ano, eu tinha a disciplina da reumatologia que era muito difícil, eu quase bombei. Eu fico pensando, se eu tivesse a Aline para me explicar artrite reumatoide, com certeza aquela prova teria sido bem mais fácil.
Quando eu comecei a entrar na área do ensino, eu ficava maravilhado, velho, eu consigo impactar positivamente na vida de diversas pessoas de uma vez só. O número de pessoas que eu estou impactando, velho, que eu estou ensinando e capacitando eles para que eles vão e na extremidade lá possam ajudar as pessoas e melhorar, sabe? E fazer um atendimento adequado, fazer um atendimento bem feito. Isso é sensacional, velho. Isso é muito reconfortante.
Estudar medicina não pode ser caro, tem que ser fácil. Aproveite nossos planos e assine agora. A partir de R$19,50 por mês você pode ter acesso a todo o conteúdo sem restrições. E se você ficou ainda na dúvida e quer fazer um teste, fique à vontade. Experimente seu Netflix por 7 dias agora.
Hi. Just gonna share screen. Can everyone see it and hear me?
Yes.
Yes, we can see and hear you.
Okay. So hello, my name is Rafael. I'm a second-year medical student of the Centro Universitário de Saúde ABC. These are my fellows, Gabriela and Kaisan. They are here in this call too. And I'm going to present the first Brazilian case report of mania associated with Cabergoline. So, just a minute, okay. So Cabergoline is a highly effective dopamine agonist agent to reduce prolactin levels. It has adverse side effects. I'm sorry? Okay. So,
yeah, I sent my question in the chat already.
I'm sorry?
We went to the next presentation. Now it's Rafael Barreiro.
No, I sent my question already. She already replied.
Okay, perfect. Now we're listening to Rafael Barreiro's.
No, she already replied my question. Thank you.
Okay, no problem. Now it's the next presentation. You can go, Rafael. Thank you.
Okay. So as I was saying, Cabergoline is a highly effective dopamine agonist agent, and it reduces prolactin levels. It has adverse side effects such as cardiovascular, gastrointestinal, and neuropsychiatric, common to other drugs of the same category. There are few reports of patients that develop a mania episode in international literature, and this is probably the first one in Brazilian medical literature. Case report. NMGF, male, 69 years, born in São Paulo, smoker. He had no family history of psychiatric disorders. However, he had a personal history of depression. Because of that, he was administered escitalopram 10 milligrams daily for 3 months. He was identified with high prolactin levels. So the first conduct was to withdraw escitalopram correctly for 4 weeks. However, prolactin levels were still high, and exams indicated a pituitary microadenoma. The medical conduct was to use Cabergoline 0.25 milligrams twice a week. After 24 days of treatment, his wife described a relevant behavioral change, such as irritability, impulsiveness for tobacco, binge eating, verbiage, disconnected and accelerated thoughts, reduced need for sleep, and increased libido. These symptoms are consistent with a manic episode. In the Altman Mania Scale, EACA, or CARS-M in English, was administered by a psychiatrist. The value obtained from the test was 19 and indicated the presence of moderate mania. Cabergoline then was suspended and lithium was administered. The clinical condition evolved with symptom improvement. The correlating of mania and the brain dopaminergic pathways are recognized. Cabergoline, a dopaminergic agonist, can stimulate these pathways. The patient didn't administer any other medication that could cause these conditions. The correct withdrawal of antidepressants, like escitalopram, doesn't induce manic episodes. Besides that, the patient showed this symptom 3 weeks after the first administration of the cabergoline. He got better rapidly after he stopped taking the pills and started using lithium, ratifying the diagnostic hypothesis. So to summarize, the behavioral change must be observed and questioned by cabergoline users. Even though it is a very safe and effective medication to reduce prolactin levels, it could induce psychiatric side effects associated with it. Our acknowledgements. We would like to thank Dr. Ana Beatriz de Freitas Castro Marques and the Dr. Luis Ricardo Hart de Siqueira Filho for offering us the case discussed here. And we are very grateful for their trust and for their help throughout the study. These are our references. And thank you very much for all the attention.
Thank you, Rafael. Now we pass the word to Alessandra.
Hi, another one really nice presentation. Congratulations, Rafael, really good English.
Thank you.
So my point is, the main point is about, because we know about the escitalopram was withdrawal correctly. You mentioned this all the time during your presentation, but this patient was your patient here in your university? Did you see this patient?
No, not actually.
Because my question is why the doctors did not prescribe another one antidepressive medication for the patient, because I don't know, the 3 weeks is sufficient to say that escitalopram, there's no connection between the withdrawal of escitalopram and mania episode, because we know from previous literature that there is some association with unipolar depression and correlated with withdrawal with escitalopram. So I know about the association with Cabergoline and mania, but I don't know if I'm sure you can say that. There's not about escitalopram withdrawal, you know what I mean? So what's your opinion, since that you don't know the patient?
Actually, because of the high prolactin levels, they thought they should withdraw the antidepressants.
Okay, but all of them, because this is not my area. I mean, I'm not psychiatrist, so that's my question.
Yeah.
When you have these high levels, you cannot use the other one because you have this possibility to, when you
actually,
right? To have a mania episode.
Yeah, actually, both doctors they thought it was better to withdraw because it's a side effect, the high prolactin levels.
With all medications to treat depression, you can have this effect. This is my point. You know what I mean?
Yeah, actually, it's not, but it's from escitalopram. It's a side effect, and I don't actually know why they didn't use another antidepressant. But I think it's a very good point, and I think we're gonna
because this is one limit. I'm just mentioned because can you imagine one reviewer if you send your case report for a publication one more time? This is a limitation, right?
Yeah.
is a case report, okay. You point out this very well in the beginning of your presentation, but in the same time, you have to put the limitations because you have a depressive patient without medication at all. So the Mania episode was, how can I say, was possible to occur in this patient. It was not no sense to thinking about, you know, only to think about the association with Cabergoline and the episode of Mania. So that's my point. I think you should point out this point. You should point out this issue, like a limitation of the case report. You know what I mean?
Actually, they use lithium as an alternative because lithium is used as an antidepressant, and I think maybe they didn't want to use another antidepressant besides escitalopram, and then they traded it by lithium, you know.
Okay, so you have to put all this information, add more information if you think to report. But
yeah, thank you.
That's it. Thank you.
Thank you, Alessandra. Andrea, now please. I'm sorry.
Hi, Rafael. Congratulations. It was really nice and really clear. I think also, again, it helped your presentation, and I know it's a lot of information to put it on. Is it my area? So I'm gonna give you some thoughts for you to think about it and to address them if you're thinking about publishing, because I think you should. First of all, I mean, I think be careful when you're using the withdraw with instead of saying discontinuation of the medication, instead of withdraw, because when you're saying withdraw, sometimes it's more showing as if you're having withdrawal symptoms, and that can be yes or not. So you're taking out escitalopram, and again, she already addressed the issue about, I think first you need to kind of describe a little bit, okay, if you can take it off some antidepressants from a patient, but how he was. So he didn't have any more symptoms. He was already, how many months he was taking the medication, and then he was asymptomatic. So they decided to take it off. So I think those points need to be kind of, you can describe this in your case. And in your case report, and you say they have behaviors, symptoms of mania. You in your presentation you describe them, but you didn't describe them in your case here. So I would think about it. Another thing that's very common in the literature, and that they're going to ask you, it's very common that patients supposedly has a diagnosis of unipolar depression, but indeed they are bipolars with hypomania phases that was not recognized. So not only mania, you also need to kind of screen a little bit them from hypomania before, because that's very common that you have like patients taking medications, antidepressant and unipolar, but they had a bipolar, really. Another point, like I put it, I saw here is that the Altman, the screening that you use is a screening, right? You cannot make a diagnosis based on that screening. So be careful when you say that, because you're just screening for the symptomatology and severity, and that doesn't give you the diagnosis. So because otherwise they're gonna pick it up on that. And the lithium that they put it on, Rafael, I think that's because the patient developed symptomatology of mania. Lithium can be used as an antidepressant, but he's really a mood stabilizer. So when the patient became like with symptomatology of mania, they couldn't go back to any kind of antidepressant. So they kind of add on the lithium. That I think that was the best way to kind of cope, to control the case. So, and my question for you also, to just by the end, when you're saying the conclusion, I think like you just have to be thinking about it. So my understanding that you said like that you have to be careful when using that medication because that can lead to those symptomatology, and that's already known. So what would be your main message here that you would like to highlight for this? everybody should not be using? Because at one time point I understand that, oh, we should not use this medication, or what is your message?
No, actually, I think we should use it, but carefully, you know, that people need to know that it can happen. People need to be alert.
So perfect. So it's so say it then, and because otherwise it's to say it cannot be done. No, it should be done, but people know, the doctors who are prescribing should be aware of that, right? And that's why we're emphasizing. Yeah. Good point. Great. Congratulations.
Thank you.
Thank you, Andrea. Now, Estelle, please.
Oh, Rafael, congratulations. Congrats. Your English is very, very good. And your presentation also very, very good. But I have one question for you, because my colleagues already point out the main problems that about this, the confusion about the when you drop out the citalopram, and then they already is taking Cabergoline, and it's very confusing. You must really point out how long he takes citalopram, how long you you stop the use, and this is very, very, very important. But the main question for you is, what do you think? This patient had organic lesion in his brain. He had really a tumor, a micro tumor, but a tumor, and you keep going with Cabergoline, even with this side effects, because you need to stop the prolactin. And what do you think about it? You keep going with lithium and Cabergoline, or you will go stop Cabergoline and go on lithium? What do you think?
Yeah, actually, after the screening, we had a lot of images, and we took the patient off Cabergoline, so the prolactin started going down. Yeah.
So, well, good. Thank you. Congrats.
You're welcome. Thank you.
Thank you, Estelle. Now, Fernanda, she's going to send her questions on the chat room.
Okay.
You. What is the long-term medication for the patient? Does he need to take it for the rest of his life?
Well, actually, I don't know about that. I should check with my peers.
Thank you. Fernanda, do you have any more questions? Okay, perfect. Thank you, Rafael.